So here we go, everybody. And we are here in September. And I can't believe it's already September and so close to the end of the year already.
Mhm.
It is my honor to bring to you another meeting of the Appalachia Partnership Consortium. Today, we're going to be talking about the International AIDS Conference that was in Brisbane, Australia, just a few months ago. And I've got three extraordinary people, Nicole, who I'm just meeting, but Dr. Eugene McCray. And I don't know, Nicole, you a doctor or not? I don't want to.
Not yet. PhD student.
Okay, very good. All right. And so ABD, and that's everything but the dissertation, right?
Right.
And Dr. Chris Beyrer. Now, before we get too far ahead of ourselves, we are here to talk about the International AIDS Conference. But for those of you who don't know these people, I'm going to talk about them a bit. First, I want to talk about Eugene. And, there are people who I think enter into government service. And so often we think of government as just being a big, giant bureaucracy and that is not comprised of people. I think Eugene is one of the people who, in his service to our country and in his service for us in public health, was the example of public health and bureaucracies being comprised of people. He was accessible, he was knowledgeable, and for those of us in community, he often shined a light on areas that we didn't always see. Sometimes he told us to shut up and sit down, stop all that yapping, but sometimes he said, here's the path forward. And I think with Chris and Dr. Beyrer, and I will get back to that later, I think that his work in the research space, and particularly around developing community researchers, supporting community researchers, advancing community-based participatory practice research in a number of areas, in a number of fields, from HIV vaccine research to more and more and more and more. And so, frequently you don't get a chance to say thank you to some of your heroes, but I want to take a moment to say thank you before we kind of move on to this conversation about IAC. Some people refer to it as IAS, that's the International AIDS Society, and they put on IAC, which is the International AIDS Conference every year. Now, this year in Brisbane is what was called the scientific year. So one year is heavily science-based, and then the next year is community and science-based, and that's a whole nother can of worms, and we can get into how that all happened, but we'll save that fight for another day. So what I want to do is that I'm going to start with you, Eugene, and talk about, first, introduce yourself to the people, and then tell the people what you did, what you're doing, and what your IS or IC experience was like.
Perfect. Okay, I'll try to be brief. So, as Tony said, I worked in public health as a epidemiologist, medical epidemiologist for 30 plus years. My last 7 years, from 2013 to 2020, were spent as director of the domestic HIV program. And so I had the opportunity in that position to work with a number of academic as well as and a lot of community folks, and of course with all of the public health departments throughout the U.S. And that for me was an experience unlike I had had in my previous years at CDC, which were mostly international. I was also the first director of the global HIV program at CDC. And so I moved from there to domestic. And anyway, so I retired in September.
Wait a minute, Eugene. You just ran through that like you said. I was at the Wendy's drive-through, and then I moved up to working on the fry machine, and and what I need people to understand is the significance of the positions that he just gave you, right? And okay. So this isn't, and so I mean, and I want to do it for two reasons. One is I don't want to just blow over it. And number two, I think people need to understand, I mean, this is my call. So hey, people need to understand who you are.
Okay. I
So
didn't want to
tell
talk
me
too much about myself.
what was the global director responsible for, and what were you responsible for? So these people can understand who they're talking to and who they have the honor of speaking with today. And Chris, I'm gonna do
Okay,
the
okay.
same for you.
Just to back up, in 1999, President Clinton started something called the Leadership and Investment in Fighting the Epidemic. He gave a certain amount of money to CDC and to other federal agencies to start global HIV prevention programs in Africa and Asia. So I was the first director of that program. We started programs. We started initially in 14 countries. By the time I left in 2005, we were in 28 countries and 3 regions. And so I was responsible for leading that entire effort in collaboration with some other federal partners. And then after getting those programs up and started, that morphed into what was called PEPFAR. So I was one of the original people involved in the conceptualization of the president's emergency plans for AIDS relief that actually got off the ground in 2005 when I decided it was time for me to move out of the way and let somebody else come in. And then I left global HIV and moved over to global tuberculosis, which I did for another 7 years. And then, but in global tuberculosis, I continued to work very closely with the HIV folks because we did a lot of work in HIV and TB, both prevention as well as we did a lot of epi and treatment studies. We became very engaged with NIH in doing clinical trials, et cetera. And then after that, moved over to do domestic HIV. And actually, that was, so why did I decide? I was actually getting ready to retire, but I was approached about applying for the domestic job because at the time, I had not kept abreast of what was happening on the domestic front, except, I knew had lots of friends that were living with HIV, et cetera, et cetera. But when I saw what was happening with what was going on with the epidemic in the US, I thought the time was perfect for me as a Black gay man who was also living with HIV to be involved and lead that program. And so I led that program, the domestic program, clearly I had a personal reason for doing it, but I also had, I was motivated to do something to see if I could address some of the inequities that we were seeing among Black and brown people in the epidemic in the US. And so that's why I decided to take the job. I had no idea what I was getting into. I didn't know I'd meet people like Tony who would tell me, "Oh, Eugene, that's bullshit," or whatever she was saying at that time. But anyway, it was a wonderful 7 years, and then I retired. And since I've retired, I have had to take about a year and a half off of hiatus. But I've been working with community organizations and also doing some consulting and advisory work for a couple of organizations. Gilead is one of them. And then I'm also working with the Business Coalition to End the HIV Epidemic. I'm an advisor for them. And so, because I'm very interested in public-private partnerships and the role they can play in addressing HIV.
Perfect. Thanks, Eugene. And I know that you're also on the board of a good partner of ours, and that is True Evolution, who we started the Rural Health Service Providers Network with, my good friend Gabe Maldonado. I know you also chair the board at AIDS United, who may or may not be on this call today, but typically are. And so I think that, again, it's critically important that we keep folks like you engaged on a multitude of levels. So thank you so much. And I'm going to go over to Chris now. Chris, what have you been up to? Because you were at Hopkins and then you went to, I don't know, Ikeda Bikeda, and then you came back and went to Atlanta, and then I don't know. So tell us what's going on with you.
Well, thank you so much. Good to be with everybody. Great to see you, Eugene. So I'm also a medical epidemiologist, and I spent, as Tony said, most of my career at Johns Hopkins at the Bloomberg School of Public Health, and worked in the early years after I finished my training in Southeast Asia, in Thailand. So I lived in Thailand from 1992 to 97, and have really continued to collaborate with colleagues and friends there ever since. In the early 2000s, I worked with the beginning of the HIV vaccine effort, the HVTN as it was called, as an epidemiologist, basically because there were at the time no funded sites for HIV vaccines in Africa, no African partners. And it was seen as just a huge gap. That sometimes happens with competitive grants. You know, the US investigators were very, very experienced, put in these great grants, and Africa ended up without any partnerships. So I spent several years going all around the continent, meeting investigators, community groups, going to hospitals and clinics, and trying to see where we could jointly collaborate on this work, because of course Africa has a huge need. It's always had the biggest burden of HIV globally, and had a huge need for both research, capacity building, training, and vaccine science. And that was very, very eye-opening. I've worked in a lot of challenging environments in Burma, now called Myanmar, in Russia, in a number of places. China, where it also was very clear to me that the social determinants of health, the social justice issues, the human rights issues.
Whoa, Chris, what is a social determinant of health?
Social determinants of health are the aspects of where people live, work, get educated, the kinds of ways that they make a living, all the social impacts that really play an important role in health. In HIV, for example, we've known for a long time that social determinants like unstable housing and unemployment have big impacts on whether or not people can adhere to their medication if they're living with HIV, or get involved in prevention like PrEP or other kinds of prevention approaches. So social determinants play a really big role, and human rights is one of those social determinants, the human rights context. There wasn't a lot of work going on in this area at the time, so I started a Center for Public Health and Human Rights at Johns Hopkins, and which I led for a number of years. And I worked closely on these issues with Archbishop Desmond Tutu, who was a giant in the field of social justice, of course, although coming from a faith place. But I ended up I used to ghostwrite for the Archbishop. I wrote a lot of his LGBTQ rights material, and ended up being the Desmond Tutu Professor of Public Health and Human Rights at Hopkins.
Wow.
And I did that until last year. Just this last year, I have moved. I left Hopkins after 30 years to become the director of the Duke Global Health Institute. So I'm coming to you live from Durham, North Carolina. My new home, and
so Chris, let me ask you a question, and I don't need you to answer it now, but I want you to think about it, so when I come back to you, you'll have had time to think about it. And I know we're here today to talk about IAC, but I want you all to be thinking about, you know, kind of the reality, right? I mean, because I believe that there are lessons that we can learn from Africa. Like one of the things that, you know, was a program that we had instituted very early on was about using cell phones. That was technology that had to happen in Africa before it had to, you know, being digitized anywhere else, because so many African nations only communicated through the cell phones in that way. And I think we were late adopters to that. You know, in our area, I would honestly say probably our most prolific researcher is probably Dr. Sally Hodder down at WVU, and her center down there, but they can't do it all for the Appalachia region. You know, certainly we have Marshall University and the team over there that's doing some great work there. But I want you all to, because I'm going to come back to you on this, how do we get people interested in this area of the country and this population of people from a research perspective? Because my argument is that if we don't study it, document it, we then can't make the argument of need often. And so whether it's you look at EHE dollars or you look at other ways in which resources are distributed and disseminated throughout this part of the country. And when I say this part of the country, I mean the 26 million people of the Appalachia region. I mean the 13 states of the Appalachia region. I mean being able to move a grant across state lines. That's what I mean. And I think that that's kind of our goal. Our mission here is to bring resources, opportunity, and spotlight on this region of the country. So when I come back to you, I'm going to ask you all about that as well. I know we're going to talk specifically about the things that you know about and did. And Chris, I know you weren't at IAS, but you were like the coordinator of the captain, and you were in the captain seat for IAC for a long time. So I also want to talk about process, about how more people on this call can do things like submit abstracts, be volunteer, all of the ways in which we're trying to get people in this region engaged in both domestic and international research. So I'm going to come back to you with all of that stuff. Again, Chris, you may have missed it. This is like just think about this as us having a cup of coffee and a conversation. Don't be, if you like, I don't know, you can say, I don't know. And we'll get the information out to the folks later on. But that's this piece of conversation, if you will. Nicole, I'm going to come to you now. And I know you actually had a poster at IAC. Was this your first poster at an international meeting or no?
No, I had a poster when the conference was in Mexico City and then also in Montreal. But this was the furthest I'd travel for sure, going all the way to Brisbane. Mm-hmm.
So tell us about your poster. Tell us about you. And
yeah, definitely. So like Tony said, my name's Nicole. I'm an epidemiology PhD student at UNC Chapel Hill. My background, I originally got involved in the HIV field after college. I did my undergrad at UNC as well, and went and joined AmeriCorps and was working in a community health clinic and an HIV clinic. And so from there was seeing what Dr. Beyrer mentioned, all these social determinants of health, everyone who was coming in having trouble accessing their HIV meds or their preventative meds like PrEP. It was all due to these social factors that Dr. Beyrer previously mentioned. And so from that, I kind of got involved in social epidemiology research related to HIV. I did my master's in public health in epi at UC Berkeley out west, worked for a little bit in the HIV research field, and then came back to UNC for my PhD. So in terms of this work that was presented at the conference, it was done with a big team they used to be based out of UNC. They recently moved to Florida State, but are still, in this region of the country. I don't know if anyone is familiar with.
How does that, explain to people how that happens, like that your team is in North Carolina and now they're at Florida State. How does it?
Yeah, well, they still all live in Durham, which is funny. But that's a different story. So basically, there's this big research team at UNC. There are two professors that lead it, that do great work. And they have a team under them of research assistants. They have a community advisory board, and they hire those people on as employees. So they have this team of 20 plus people who are all UNC employees. But, things change in academia. People move institutions. And so they were offered to start this new institute on digital health at Florida State. So using different like apps on your phone and whatnot to improve engagement in HIV care and whatnot. So that's how they ended up moving from UNC to Florida State. But they're still in North Carolina, technically.
There you go. All right, so tell us about your poster.
Yeah, the poster. So even though this conference was supposed to be focused more on the scientific aspects of HIV, ours was definitely more behavioral and social. So we were looking at PrEP, which I'm not sure if everyone here is familiar with PrEP.
But tell us what PrEP is.
Yeah, PrEP is an HIV prevention medication. It can take multiple forms now, but for today, I'm just going to be talking about this pill you can take every day. That if you take it every day, it's almost 100% effective at preventing HIV acquisition, which is awesome. There are also other benefits of PrEP. You don't have to rely on a partner like with condoms. You can kind of take that upon yourself to get a prescription for PrEP. It can be more discreet. But even though there are all these positives about PrEP, still not enough people are using it in the US, especially among young people and young queer people, which is what our study focused on. And so we were seeing, just anecdotally, and also in research studies, people were saying, oh, young people aren't using PrEP. And that's because their brains are developing, so they're making riskier decisions. Their risk perception is altered during this time. When everyone thinks of a teenager making risky decisions, that's kind of what people were envisioning, but relating that to, okay, because your brain's developing, you're not taking PrEP every day like you should. But there actually, when we looked, there wasn't really much scientific evidence to back up the fact that this change in risk perception was affecting PrEP adherence. So taking PrEP every day. When I say adherence, I just mean taking PrEP.
So Nicole, I told you I'm a little, these calls I'm a little rude, so I'm gonna jump in.
Yeah, go for
it. So what you're saying is that there was a study that said that young people, and I'm imagining that's people under 24, right? Their brains cognitively hadn't developed enough for them to say, oh, hey, there's this risk of HIV out there. I should probably take this pill to prevent it. That the anecdotal evidence was saying, or the people on the street were saying, hey, their brains are soft. They don't even have enough common sense to take a pill, and so we need to figure out something else. Is that what you're saying?
Exactly, Tony. So it's, people on the street, even some medical providers that are hesitant to prescribe PrEP to young people. And then the research I was talking about, it's actually more of what they call a narrative review. So it's experts who are talking about a certain subject, but that's not really based on data from a trial or some other research study. It's just what the experts think. So we wanted to use some actual data. We had access to data from a study that was done throughout the US in queer youth, ages 16 to 24, like you mentioned. And so we wanted to see whether their perception of HIV risk, so how likely they thought they were that they would get infected with HIV, if that was correlated with whether they were actually using PrEP and using PrEP like they should, taking it at least 4 times a week. And tied into that, we also wanted to see how their sexual behavior impacted both of those things, PrEP use and risk perception, because say you're not having sex, you might not need to be taking PrEP, right? Versus if you're having a lot more, let's say, condomless anal sex, where there's a higher likelihood of HIV acquisition, then you might want to be taking PrEP more regularly. So our study was looking at all 3 of those things and whether there was actually a connection between them.
Well, let me ask you this. Are there studies which look at substance use in this same or similar population? Because I think folks on this call, right, would probably be more likely to have an individual patient or individual client who was impacted by substance use disorder than anything else, right? And I think that one of the things that and I know y'all we got on here to talk about the International AIDS Conference. She all over. But that's the way these calls go. But one of my big things and one of my big pushes in the next year is to really look at medically assisted treatment providers, because I don't believe that we have gotten them as a part of our continuum of care around HIV and viral hepatitis. I believe that the 50% of cases that we can't find for Hep C are in those MAT providers. And I think a high percentage of the HIV cases we can't find are there as well. I think we have to educate them on everything from 340B access to how it is that they can screen these individual patients and clients for HIV, but we also have to make sure that state-based policies allow them to screen and that they're not allowing folks to opt out. So did you see any more or a higher rate of substance use disorder in this population? Did you control for that, look for that? I'll stop talking now.
Yeah, that actually raises a great point. We didn't look at substance use disorder, and that's something that would absolutely affect your adherence. There are other studies, and I'm sure, Eugene and Chris could speak to this as well, that talk about how, risks are inhibited especially among young people when substance use is involved. So I have to say, I don't know. But I did really like your point about medical providers and screening. And I think that's something we were thinking about with our study as well, is not to skip ahead to what ended up happening, but we didn't see a connection between risk perception and PrEP use. So we're saying, okay, risk isn't driving this. Risk, you can't scare kids and youth into taking PrEP. That's not going to work. So we need to identify these other barriers or motivators and work with providers and train providers to recognize those instead of using, the traditional risk assessments you'll see in a clinic.
Right. All right, now we're gonna pivot and I'm gonna come back. Eugene, you actually went to a session, is that true? Because I just go there to socialize and I try to get all my work done in the hallway. I get my tag so I can look official, but I think I try to have. But you actually sat on panels and went to sessions and whatnot.
Yes, I did.
And I understand from Lee that you took. I understand the word copious notes got used. So tell us about your experience at IAC.
Well, I mean, yeah. So I participated in a couple of panels and talked about rapid initiation of ART treatment.
Whoa! Slow down. What does rapid initiation of ART mean?
Basically, we believe that every person living with HIV has the right to live, a healthy life, and that begins when they get with a diagnosis. If somebody's living with HIV, they need to be diagnosed, and when they're diagnosed, they need to be rapidly. We are now encouraging people who are eligible and who are willing to do it to rapidly initiate ART treatment. That means getting them on treatment within 0 to 7 days. And if they aren't willing to start, then you continue to work with them, support them so that they are able to feel comfortable starting antiretrovirals as soon as possible. And there's
what's the difference? What's the difference if I get on it at day 7 or if I get on it at day 700? What's the difference?
Well, there's huge advantages to starting the therapy early. And there's a number of studies across the globe that have shown that rapid ART, well, number one, it leads to very rapid viral suppression, leads to viral suppression, early viral suppression. And with early viral suppression, it leads to decreased morbidity and definitely decreased mortality. The other things that it does is when you get on treatment early and you become virally suppressed, there's also benefits to you as an individual, but also to the community in terms of the decreasing transmission. There's also the data also shows that people who get on treatment early are also more likely to be retained in treatment, and they are empowered in many ways to really take responsibility for their own health. So it's an empowering thing for people who are living with HIV. So that was a big discussion and theme at the conference, a rapid initiation of treatment. But I want to make sure people understand that when you talk about rapid initiation, you cannot do this without actively engaging the patient in the discussion about starting therapy. The patient needs to be fully engaged and they need to feel comfortable getting started. And you need to work with them so that they get to the point that they're comfortable getting started. So that was one thing.
So you're saying, so wait a minute. So you're saying that what we can't do is just say, this is what we're doing.
That's right.
We have to engage the individual in their own healthcare to some extent.
That's exactly right. So part of this idea of championing sort of what we call an HIV neutral status and what we call comprehensive care for individuals is this idea of comprehensive patient engagement at all levels in their care, and that's something that was a big theme in many of the countries, especially Australia, where the conference was being held. This is something that they actually promote in their entire health program, and as a matter of fact, they are actually have done a great job getting people in care and preventing transmission of HIV. I mean, they actually were what I would call a model for HIV prevention and care around the world.
And so Eugene and Chris and Nicole, this is kind of like the one of the challenges in Appalachia, right? Is that there was not and has not really been a huge HIV infrastructure, right? So if I look at cities like Brisbane, Sydney, or Washington D.C., New York, Chicago, they had these HIV infrastructures that I could integrate the substance use disorder piece to, the Hep C piece to. When I look around Appalachia, it's that, what I like to say is, and everybody on my team will kill me because I'm going to use it, is that there is a train that's roaring through Appalachia. The engine of that train used to be injection drug use. Now it's poly drug use. Then there's hepatitis C, hepatitis B, hepatitis A, workforce development challenges, economic development challenges, educational attainment challenges, and the caboose of that car is HIV. And then what we need to do is think about that train as being laden with coal, the environmental impact of coal, the economic impact of coal, and the psychological impact of coal. Now, our job on this call is to stop that train in its tracks. But the problem is, in many cases, there was no track laid, right? That's the problem. The problem is that we're now looking at an HIV outbreak in West Virginia that some say they didn't see coming, but it was so easy to kind of see 5 years ago with the combination of factors that we had. So when you talk about the ability to address someone's HIV status and to have them be able to, in effect, have a undetectable viral load, which is what this is all about, right? Is that if we don't have the infrastructure, right, here to be able to meet the need when John, Jay, or whoever, or Billy Bob or Willie come up and say, I've now got a reactive test. If I got no provider to send them to for rapid initiation, what do I do?
Yeah, and others can respond to this, but there are a number of innovative approaches that people are taking, and part of this is decentralizing healthcare and making sure you're bringing the care to where people are. So, for example, in Australia, and in other places too, they are actually doing more care at the community level, and they're using ancillary care providers. So getting the pharmacies involved, getting other healthcare providers involved that are not specific HIV care providers, so that you're getting the care closer to where people are. And sometimes just having conversations with the communities can help you identify where people would want to get their care. And then you have those care providers, non-traditional HIV care providers, linked to HIV care providers and other resources that they can access via telephone, via internet, et cetera, to provide support, et cetera. And then the other thing that they've employed a lot is this whole concept of having peer providers, peers involved in helping support people when they are diagnosed. Or
so in other words, what's old is new, right? I mean,
what's
like
old is new.
What's old is new. Buddy networks, when we first started out HIV 30, 40 years ago, it was that buddy network that got that person to care, made sure that person got their medication, make sure. And I honestly think that we are back there, right? Where, especially in a place like Appalachia, where I think that we need to figure out how we're going to train community health workers, which is a bit of what we're doing, but to go into the hollers with rapid HIV tests, rapid Hep C tests, whatever rapid test, whether it's a colorectal screening, whatever it is that we need to be able to do to get that information and care there, and then get that information out, and then but be able to bring providers in. And I think it's a bit of what I was saying earlier about figuring out how the central place or the central organizations that are touching the people we need here are these MHC providers. And they right now don't see themselves as a part of our continuum of elimination or eradication or reduction of HIV and Hep C. All right, I know I told you, okay, go ahead, talk about the rest of just talk about the other 2 or 3 workshops you did, then I'm gonna go to Chris because Chris is
Well,
chomping at the bit.
I actually I don't, but I don't want to talk about the other workshop, but what I want to mention are some of the prevention related stuff that was like that I thought was exciting,
Okay.
and yeah, one of them, and maybe Chris could talk about this more, was in one of the plenaries there was a presentation that talked about doxy-pep, and let me tell you what I mean by doxy-pep. Now you know that in the U.S. there has been a rapid, a huge increase in sexually transmitted infections, especially
And you
among
mean like that's like syphilis, gonorrhea, chlamydia?
well, gonorrhea particularly, and that's
Right.
what doxy-pep is all about, is gonorrhea prevention. So and that of course that plenary was very well attended because everybody was sort of interested in hearing what was going to be said about doxy-pep. But the main, I mean, I guess the main points from that whole session was that doxy-pep can be an effective prevention strategy, but it should be targeted. You should use it to target a certain individual. And people may not, when I say PEP, I'm talking about pre-exposure prophylaxis using doxycycline, doxy-pep. And
Right.
what
And that's different than PrEP because you're saying
that's right.
Right. So you're saying pre-exposure or post-exposure. Which one? So
No, but actually with doxycycline PEP, they use the word PEP, but basically what they recommend is that for men who have sex with men and transgender women with or without HIV, if they're going to have sex with casual partner without the regular use of condoms, they should consider doxycycline pre-exposure prophylaxis.
but Eugene, this gets to my earlier point about people with lived experience around substance use disorder.
Uh-huh.
I think that would be the third arm of that trial. Because if I'm coming to it knowingly and I have an opportunity to have this preventative structure here for me to use, but I don't know that I could be preventing, because I mean, again, when you look at rates of gonorrhea, you look at rates of syphilis, I mean, that this is the third rail of that population. But
yeah.
Right, sorry, go ahead.
Well,
yeah, but anyhow, what was interesting, I mean, so that was a very well attended session, and there's still people who are skeptical about it because of all the problems we are seeing with resistance outside the U.S. and beginning to see some in the U.S. But one of the things that they did I thought was interesting. He had a big picture of a pig on the screen and says, if you spend time around pigs, you're probably not a candidate for this. And I said, I had no idea what he was getting at. And then I realized, because he didn't say it during the presentation, but then I looked it up and I figured out what was going on. And that is that because if, pigs apparently are infected with, can be infected with a strain of chlamydia called chlamydia sui, like sui. But anyway, and it can also infect humans. And so if you're around pig, you may have a resistant strain of chlamydia, so doxy won't work.
Well, isn't that what they said about the koalas and why we weren't supposed to go touch the koalas while we were in Australia because they had chlamydia too?
I wouldn't know that. I wasn't out gallivanting. I was actually at the conference.
Excuse me, sir. I'm gonna go to my good friend Chris.
Well, I'd like to respond, I think, to a couple of things that were said. First of all, yes, it's true. I was president of the International AIDS Society, which puts on the conferences from 2014 to 2016, and I had the good fortune to chair the Durban AIDS conference, share it with Olive Shoshana, my great friend there, who now is in the cabinet in South Africa. And also the Vancouver IAS Science, the ISC Science Conference in Vancouver in 2015. And I led these conferences are partly funded by NIH grants from the National Institutes of Health. There are R13s. And ever since the 2012 conference in Washington, I'm always the PI of those grants. So I also was the PI of this one for Brisbane. And that allows you to kind of shape it. I did attend virtually, and we did a session reporting on a commission that I am co-chairing for the International AIDS Society and the Lancet. It's a Lancet commission on the
Hey,
future.
Chris, what's the Lancet?
The Lancet is the leading global health journal. It's out of the UK. It's one of the top 2 or 3 medical journals worldwide, but it really is a kind of the leading journal on global health, international health as well. And they put together these commissions to take on a big topic, much longer than you can do in a short scientific paper. And I've done several of these, and I've also done guest edited special issues of the Lancet for each of the international AIDS conferences. So we did one on HIV and men who have sex with men for Washington, D.C. We did one on HIV and sex work for Melbourne in 2014. We did HIV and substance use for the Vienna AIDS conference in 2010. And then just recently, when we were going to have the International AIDS Conference in San Francisco and Oakland, we did a special issue on HIV in the United States. And because we were coming back to the States, of course, that ended up being a virtual conference because of COVID. But Sally Hodder led the paper on opiates and HIV in the United States, and we worked closely together on that. So a couple of things to say. One certainly is that there's only ever been one trial of PrEP, pre-exposure prophylaxis, for people who inject drugs. That was done by the CDC. Eugene will remember it. Some years ago, and it was done in Bangkok, Thailand. And it actually showed quite good efficacy of PrEP among Thai people who inject drugs. And that epidemic actually also has quite a lot of women who use drugs. So they had a substantial proportion of the population was women, and the efficacy was even higher among the women than among the men. And that's probably because PrEP was also preventing more sexual transmission, which is a big issue for women who use substances. Interestingly, that trial was done just with tenofovir. So it was before Truvada. It's called the Bangkok tenofovir trial. But it's really the one randomized controlled trial we have that shows that PrEP, oral PrEP, with tenofovir at least, prevents HIV in people who inject drugs. So it's a landmark study. Right. But unfortunately, the adherence, the uptake, the use of PrEP in this population has been historically very low. It has had very little impact. And that is starting to change. So the good news is there was a very nice presentation, for example, from Vietnam, which is a country that has long had an epidemic of HIV among people who inject drugs, also Hep B and Hep C. And they reported, having more than 85,000 people on PrEP, a substantial proportion of them drug users. So that was impressive. And they were doing it also with telemedicine, with using mobile outreach, using community health workers. So I think to answer an earlier point that you raised, Tony, I think there are innovations out there that could really improve access to PrEP for this population. And that is important. I think you're absolutely right about the MAT providers. A challenge we have, and it's been going on for a long time, is that there are also associations with other substances and HIV, and particularly in gay men, bisexual men, men who have sex with men. It's not so much opiates that have been associated with HIV, it's methamphetamine. Mm-hmm. And not necessarily through injection, but rather because there are networks of people who use methamphetamine and mix it with sexual activity, including group scenes and other kinds of high risk sexual exposure. That's also a population where we see a lot of gonorrhea and chlamydia, and they're of course not really reached by opioid substitution programs. And we don't have a methadone or buprenorphine equivalent for meth. We don't have any medical intervention there. So that's a challenge. And when you look at HIV in the United States, and certainly among the majority of our new infections are in gay men, more than 65%. Of all
Chris, I'm gonna jump in. This is where I take moderator's privilege. And I think that while those numbers are really, really true, I think the challenge, however, is that when I look at rates of hepatitis C, and I look and what I think of as unknown, honestly, unknown HIV cases amongst this 26 million people, that's where I feel like we've got to do a yes and approach. I believe, yes, 100% that all of the data suggest and show, not suggest, but show us that new rates of infection are higher amongst men who have sex with men, particularly men of color. However, with the question though, is that how do I get the folks that are impacted by substance use disorder in these 13 states to see HIV and Hep C as also their battle cry as well, not just supplying the Suboxone and buprenorphine, but also doing an HIV and a Hep C screen. That's the other critical piece. I think that one of the things that happens for us often is that we say, well, if I look at it also with like Black women in PrEP, for example, across the country, they say, well, why is there such a low uptake? Well, you never have a conversation with Black men about PrEP, but you want to have a conversation with a Black woman about PrEP, but you've never talked to her partner. And that means that you've made a serious set of assumptions about the number of Black men living with HIV in this country. And that if you look at many data sets, it's like this lumping of all Black men. So it's an assumption either they're all on the down low or they're all men who have sex with men too. And I disagree with that. I think that there are men out there who don't have sex with men, but they are having sex with Black women, and we've refused to engage them in this conversation. And I think that, again, it's the same thing with people who are with lived experience around substance use disorder. It's that we want to have a conversation with them about, clean syringes, syringe access, but it's far greater than that to me, of the challenge as we move forward in trying to figure out how we eliminate or reduce, again, Hep C, and how we get a reduction in the number of HIV cases in this part of the country, but also how it is that we bring on new partners to this continuum of care of ours that we need to do. Sorry, Chris, go ahead.
Oh, no, just I very much agree with all of that, of course. I guess I would say one or two additional
Eugene,
things.
where you going? Get back here. Okay.
No, I just closed the door. That's
okay.
So first of all, of course, you pointed out earlier the rise in Hep C and now followed by HIV. That unfortunately is entirely predictable, right? And where you see, Hep C is almost like a sentinel marker, a warning. That you're having needle sharing at rates that are going to eventually will likely lead to HIV transmission. So we saw that in a number of states, and as you well know, that is where we finally broke through the logjam on a bipartisan support for needle and syringe exchange. Because of the outbreak initially in Indiana, when somebody named Mike Pence was the governor, and really finally allowed, initially just on an emergency basis, but eventually really allowed. And then the same thing happened in Kentucky, where Mitch McConnell, who had really played such a role in blocking federal funding for needle and syringe exchange, finally turned around and co-sponsored the bill. So that's important. And that really is a change. It's just very late in coming, as we all know. You will remember that DC used to have the highest HIV burden in the country as an urban center. And a lot of that was because their budget is controlled by the Congress, and the Congress wouldn't fund needle and syringe exchange in DC, and they wouldn't fund, treatment programs. So that changed. Actually, I have to say, in 2011, 2012, there was a real push partly in response to the fact that the Obama administration had lifted the visa ban on HIV, people living with HIV coming into the US. And so IAS agreed that we would move the conference back to the US. And suddenly DC, had worse numbers than some of our PEPFAR recipient countries.
Right. And so for folks that don't know, is that at that point, it was reported that DC's population, or 3% of DC's overall population, was living with HIV, and put it on the map as like one of the worst places on the planet. And in part, this is the science part, right? This is the data part. There were a lot of data that hadn't been collected for years. And then all of a sudden there was this big data jump that was like, oh my God, there's a real problem here. I think the other thing that we were able to do, honestly, and don't ever tell her I said this, but it was actually to get Shannon Hayter, who had a global background, right, for the District of Columbia. So when she came to work at the DC Department of Health, I think it was her ability to see globally that helped us to fix the problem, rather than seeing it from a local, state, or county health department perspective. She could bring the work. I think she was either the Tanzania office or something like that. And then she brought that to the District of Columbia. The other thing that happened was that there was a very strong local government and academic partnership with Dr. Alan Greenberg, Dr. Amanda Castell, who led the charge of fixing our surveillance system, because that data dump was like 5 years worth of data, and it shouldn't have gone that way. And so Dr. Amanda Castell, who's at GW, and Dr. Alan Greenberg, who's also at GW, were in charge of kind of helping us restructure that system in the District of Columbia. And so I think that's the other thing that I think we need in this area of the country, in this region of the country, is a better system of data collection, a better system of reporting those data across the Appalachia states, and making sure that we see this in a regional way, because so much of this region, the Appalachia region, isn't seen as a place to collect data for all of it. We'll collect in pockets rather than to see it as a region. I know we are at a few minutes. Daniel Raymond, you had a question. You all know Daniel Raymond, so he always is good on these calls. Don't listen, nobody get nervous. Right, Daniel? Is he still there? Maybe he left. Let me see. Is he still there? Nope, he's gone. Did anybody else have a question? Because Daniel had one. If anybody else has a question, Trisha?
I don't think Daniel had a question unless he sent you something privately. But he put in a link for they're having a summit the next couple of days that is specifically about hepatitis C treatment in various settings, including with MAT providers.
Perfect.
So that's here in the chat box.
All right, I've got Dwayne M.
Hey, everybody. I've been listening on the call. I do apologize for my attendance. It hasn't been as regular as I would like for it to be, but I will say that it's really refreshing hearing the conversation around systemic work, and really, taking, HIV strategies and trying to make sure that we're looking at Hep C as well, and how to combat those disparities. That's something that I'm looking at specifically here in Tennessee. Y'all seeing I'm smoking, I'm sorry.
I was getting ready to say, we got to send the tobacco control people to your house, but go ahead.
I know. Look,
we'll talk about that.
My vice. However, though, I wanted to definitely just thank you for having the conversation around the systemic work. This is something that we are experiencing and seeing in Tennessee. It's really interesting talking about the panel that had the what was it called again, Eugene? PEP? The
DoxyPEP.
DoxyPEP. I'm really interested to know if that's going to be something rolled out and used already. I am very interested in that. That's something that in my work being an early intervention specialist at one point, I saw continuously people living with HIV were always coming in to get their recertification and seeing the provider, and they were, having to get treated for syphilis and gonorrhea almost every 3 to 6 months when they were getting recertified. So I would wonder, like, what would that be like, or even if their medicine is for that population of people living with HIV in comparison to people who are not living with HIV. But I really, that is really thought provoking, and I appreciate you sharing that.
Yeah, no, the doxy-pep is actually is for this being recommended. Well, actually, let me just clarify. It's not incorporated in the STD guidelines as yet. This is data that was presented at the conference, and basically the guidance that was provided at the conference is that for men who have sex with men and transgender women with or without HIV, that if they are having sex with casual partners without regular use of condoms, and they've had greater than 1 to 2 STIs in the last 12 months, they would be candidate for doxy-pep. And the way you're supposed to take it is, they're supposed to test negative within 7 days of the time you started. And then of course they must not have any tetracycline allergies, but they take 200 milligrams of doxy with food and water 1 hour before bedtime, and then they take another dose 24 hours later and no later than 72 hours following the condomless sex. So it's sort of, this exposure is sort of like similar to a strategy that you would use with on-demand PrEP.
Hmm. Hey, Melissa Clark, I see you sitting there and you're actually paying attention. Did you have a question for Eugene or for Chris or for anybody, Nicole, or for me or anybody? What do you think about all of this?
No, I just was agreeing with everything. We have recently, within the last year, become a syringe service program where we are. And within the past 2 or 3 months, we have in full force been doing HCV, HIV, and STI testing regularly, once a week. That they know us, they trust us from even before we had the syringe service program, when we were given naloxone and all those things out. So when we say, hey, you need to get tested, hey, let's talk about this, we're seeing results. Of course, as part of those results, we're seeing an increase because there's never been testing en masse done. And so, of course, now that we can help them. And that's the key piece, because now we're giving them yet another way that we're helping them in addition to all the other ways we're helping them. And we're even taking it to the streets. When we're out and such, we're taking it to the streets as well as in our physical site where they come, but it's accessible to them. They don't have to go get on a bus and go somewhere, because where we're doing it's right where they are. So
can you tell the people where you are?
Sure. We're in Cumberland, Maryland, which is obviously Western Maryland, Allegheny County. And we're actually in the process of expanding our SSP services into Garrett County, Maryland as well, which we will also be including the HIV, HCV, and STI as well with that service. And we have recently, even before, like kind of as this was all happening simultaneously, our region, and we're like this skinny in Maryland and we butt up against West Virginia, there's 11 cases of HIV that were recently in our region. So CDC had contacted us to make sure that we're giving the clean needles to anyone. Like there's been this whole conversation around it. So it was kind of all happening simultaneously. Mm-hmm. But it's been fantastic. I highly recommend, I do, like, whoever can do it, do it. However you can make it happen, make it happen. And I'm always happy to share how we do it, and who we partner with and all of that. I love hearing this whole conversation. And it's one thing that has been very much lacking in our region, because folks don't think it happens here. And it's happening here and has been happening here since the, you know, the 90s. So it's so important.
Thank you so much, Melissa. And you know, I know we are at time, and Chris, Nicole, and Eugene, I want to thank you very much. But I think that that's the piece that I would like to relay to Chris, Eugene, and Nicole is exactly what you've just said. You know, after 40 years of an epidemic, people would think, well, you know, of course they know that. Of course they have access to that. Of course that's a part of their overall prevention, health prevention plan. That's all of the things, and it's not true. And that's why I need each and every one of you, when you're doing the work that you're doing, that maybe you say, hey, what about those 26 million people of Appalachia? What's going on with them? Have we included the 26 million people of Appalachia? Because this region of the country has been so overlooked for so long. Folks don't believe that they are entitled to a whole bunch of the things that they're entitled to, one of them being proper health care. And I believe that we have the opportunity, like I said, to make a grave and huge impact here. And I think because there hasn't been so much here, if we do something small, it'll have a big ripple effect. And again, that's why I want to have people like you come on to educate folks like this, and also to just let them know what's possible, that it is possible. It's possible to fix this. It's possible to address this, but we can't do it alone, like the National AIDS Strategy tells us. Again, thank you very much for taking the time out to chat with us. And I look forward to seeing you all around again. Nicole, this is the first time, but not our last time. Eugene, I'll talk to you very soon because I'll be in Atlanta soon. Chris, I'll be down there to talk to you as well, because I want to figure out how we're going to do some kind of study in the Appalachia region. I'll try to drag Sally into that too.
Wonderful. Wonderful. Look forward to it. Thank you all.
Thank you.
Thank you. Thank you. Hey, who asked you to do that?
Okay, do we need to get you on DoxyPap?
I think so. Just maybe.
Okay.
All right, everybody. Have a great week. Have an amazing weekend. Thank you so much for joining us again.
Bye-bye.